Dr. Feghali, how are you? You look so professional with your
Thank you,
glasses and
Dr.
jacket. How
How
are
are
you?
you?
Welcome. How you doing?
I'm doing great. We're
Good.
enjoying the California weather in Texas.
It's California weather in Texas?
Yes, sir.
Good, good. You're a proud father of child number 3.
True.
Yeah. Congratulations.
True. We
Good.
are.
Okay, we'll go ahead and get started. So introduce yourself, Dr. Feghali, your full name, and we'll get started.
Well, George A. Feghali. I'm one of the interventional cardiologists at Baylor Heart and Vascular Hospital, here in Scott and White Heart and Vascular Hospital. I've been in practice with Heart Place for 10 years now. Prior to that, I was practicing in a small town, Mississippi, Ocean Springs and Pascagoula on the coast. I practiced there for 4 years. I was there straight after Katrina. Prior to that, I trained at Baylor University Medical Center, interventional cardiology and general cardiology at Oshner Clinic. And prior to that, I did my internal medicine in Staten Island at Staten Island University Medical Center. And that has been the journey since 1998.
Right. So you trained in Lebanon. You did your medical school there?
Medical school in Lebanon. And, I started my medical school, and the system is somewhat different than in the US. So we start medical school from high school. So at the age of 19, I was in medical school back in 1990. And I trained from 1990 to 1998, medical school. And then we did training for 2.5 years in different hospitals in Lebanon. And I moved to the U.S. back in 1998.
98. So in Lebanon, is medical school 6 years or 8 years?
Well, 7 years in Lebanon, plus I did one internship. I did internship at American University Hospital, which is part of the American University of Beirut. So I was intern there from 1997 to 1998.
Okay, so to get into medical school in Lebanon, you go in right out of high school. Is that exam related? Interviews? How is that decided?
Yeah, so the medical school, you have to have its first year, which we call it preparatory year. They accept a lot of students in that first year. And I think, we're about 1,000, maybe 1,000 students the first year.
Okay.
Go through all these basic science, histology, zoology, psychology, a lot of things that take place in that first year. And then after that first year, you sit for an exam. And out of those 1,000, they choose 40.
How many?
40.
40.
Uh-huh.
Okay, so it's not even, so 4% of the 1,000 people get in.
Probably.
Yeah, so 40 out of 1,000, yeah, it's 4%.
Yeah.
So it's very, very competitive.
It is very competitive for a lot of reasons. One reason is back then there was only 3 medical schools. There was the St. Joseph Medical School, which was French medical school. There's a American University of Beirut Medical School, and there was Lebanese University. That's it. There was 3.
For the whole country of Lebanon, 3 medical schools?
Yes, there was 3.
What's the population of Lebanon?
Yeah, so, and let me finish why it's also competitive, because it was tuition for free. So you enter medical school, you go through 7 years of studying and training, and it was completely free. And that was the only free medical school in Lebanon. Well, yes, back then, and it's still.
So all medical schools are free in Lebanon, or just those three?
The only one.
Oh, the one that you went to.
Yes, the
So
Lebanese.
that's why it's, yeah. So obviously, a lot of people want to get in there.
Yes.
Yeah.
Yeah.
Very okay. Very good.
Population of Lebanon is right now 6.8 million.
So very small country.
Yeah.
So half the size of Texas.
Well, Lebanon is actually a little bit smaller than Connecticut.
I mean, as far as geography, but the number of people is
Yeah.
pretty small. Yeah. Yeah. Okay. Very good. So now your school, your medical school was in French, right?
Well, that's the thing. You know, it was French back in the days. Was mainly French, maybe like 5% English. However, textbooks, French textbooks back then were pretty expensive. So I remember those days where I used to, you know, buy Harrison and Cecil and all these English textbooks, and we study in French. But I used to go home and read everything in English, and that was the only way for us to.
Your image is really dark now. What did you just do?
I don't know. It's the phone keep going dark on me, so I had to touch the screen to make it light.
I see. Okay. Yeah. Well, you got dark.
Yeah. Is it better, or is it still not?
Yeah. Yeah. You need some more light in the room or something. But anyway, it's fine. We can see you fine. Yeah.
Okay.
Okay. All right. So that's interesting. So you went to, your native language is Arabic.
Native Arabic, school, high school, and elementary school French, and medical school French, and but you know, the last 3 years of my medical school, I was kind of reading everything in English. So my you know, my spoken English was not really the best when I came to this country, because we talk to each other in French, or discuss all these, all materials in French.
Okay. Right. And then, so you finish medical school there, and then you went to New York, right? And then you ended up in Oxford.
No, yeah, I went to New York initially, Staten Island University Hospital. It was part of the SUNY State, it's a state university in New York, and I did my internal medicine, and I moved to New Orleans to do my general cardiology fellowship in 2001,
right?
July, just like 2 or 3 months before 9/11.
Right, and then from Oxnard you came to Baylor and finished your training there with us. Great. So I want to jump back to Lebanon. It's a country which is really dear to us. We've traveled there, just absolutely love it. The people and the terrain is incredible. It's like combining Colorado and San Diego together with the ocean. So it's an amazing country, tremendously well-trained people there. And then recently there was a tragedy there. Tell us a little bit about that, where the explosion occurred, what the impact has been on Beirut.
Yeah, let me kind of tell you a little bit about Lebanon, and then I'll get to the explosion. So Lebanon became a republic in 1926, and got its independence from the French Mandate in 1943. But Lebanon, if you kind of look into the 10 oldest constantly inhabited cities in the world, Lebanon will have 3 out of 10. So, for instance, Byblos, there's civilization in Byblos, evidence of civilization in Byblos that dates back to 7,000 years ago, and it has been inhabited constantly for the past 5,000 years. Mm-hmm. Beirut has been inhabited constantly for the past 5,000 years. In fact, Lebanon used to be, or Beirut used to have one of the most prominent and oldest law school that belongs to the Roman Empire, and that was demolished in an earthquake back in 551 AD. And Sidon, which is on a beach as well,
What was the name of the city? Sidon?
Sidon, yeah, Sidon, S-I-D-O-N.
F as in Frank?
S as in Sam.
Sam, Sidon, okay.
Mm-hmm. I-D-O-N. It has been inhabited constantly for the past 5,000 years. And so this is a little bit of background on Lebanon, that has been, the civilization has been there for thousands and thousands of years.
Right.
And unfortunately, Lebanon has been in a civil war, as a lot of people know, since 1975, which ended in 1990. So, and it was 15 years of horrible tragedies that happened in Lebanon. We thought that after the civil war ends, we will have prosperity. Unfortunately, there's a lot of factors that led to bankruptcy of Lebanon. It's in the brink of bankruptcy at this point of time. And this explosion that happened in Beirut was a result of a lot of factors: complacency, corruption, negligence, and other factors that we yet to be determined, that have led to an explosion. And what happened in August 4, 2,750 tons of ammonium nitrate.
How much? How many tons?
2,750 tons of ammonium nitrate. To put it in perspective, Oklahoma City bombing was done with 2.5 tons of ammonium nitrate. The West explosion, it was 80 tons of ammonium nitrate. So the explosion happened in a very populated area, where the port of Beirut is surrounded by the city, by population and building, and what happened also, blocks and blocks of city blocks have been demolished. In fact, one of the hospital that was probably about 2 miles away from that explosion, I trained at that hospital, and if I remember right, back in 1995, I did a few months of training in that hospital. It was and is still the main training hospital for Lebanese university medical school. And my friend, who is still working in that school, in that hospital, actually, he was rounding when one of his radiologist friend called him and told him to come down to the second floor underground. I want to have coffee with you and maybe talk a little bit. And as soon as he got to the second floor underground, the explosion happened. And my friend described this explosion as like a giant who blew into this building, and everything is gone. Nothing's standing in that building, and everything happens within a few seconds. And people were on the floor. A lot of people got injured by the glass. Glasses were going like shrapnels everywhere. So he told me he was operating, because there is no OR in that hospital, and he was operating in the parking lot. He did a 3 craniotomy in the parking lot. He did a lot of surgery inside on the asphalt in the parking lot.
And craniotomies in the parking lot.
Yes, sir.
Yeah. And how many people in the hospital died?
Well, I've, I'm not sure exactly how many people died in the hospital, but I know the neighboring hospital, there was two nurses that died. And there's another hospital, which is a smaller hospital. Also, the two nurses died. So the three hospitals very close to each other, and there was casualties in this hospital. And I'm glad not a lot of not a lot of medical professionals got injured because they were taking care of wounded people. People on the street walking, and they were injured and died.
Right. Okay, so now you're starting a fundraiser to raise money for this hospital. It's a really tragic situation where they need to rebuild this hospital right away. I mean, it's a very important part of the medical ecosphere there.
Well, yes. Let me tell you why it's important. It's important for a lot of reasons. One reason is this hospital right now is, like I said, is one of the main hospitals in Lebanon, carrying a lot of patients that needs to be cared for during the pandemic. Right now, COVID cases has been skyrocketing in Lebanon. A lot of patients need a hospital. We have, I'm not going to give you an exact number, but we have probably 100 or maybe 150 ICU beds in the city and the suburbs. So not a lot of ICU beds in the hospital, in the country. So secondly, that's the main hospital that train a lot of, Lebanese university medical students like me. I remember back in the days in 1989, we had a horrible war that happened that interrupted my medical school for 6 months. And in fact, there was back then, a lot of rumors, or maybe funded rumors, that this medical school, Lebanese University, is not going to open again because we're not going to have funding to open the university. And I remember I spent 6 months at home, and I didn't feel good, because the only thing I want to do is to go through medical school and get to where I am right now. So it was not a good feeling, and I can imagine what those medical students right now in training in that hospital is feeling and thinking. Because the problem, you can easily, if there was not a lot of damage and not a lot of corona cases that's happening right now, you may able to place those medical students in different hospitals. But right now, every single hospital in Lebanon is suffering.
Right.
Because there was no patients going in for elective surgeries. And they're suffering because, another major hospital close to that one got demolished as well.
Okay.
So there's not a lot of, beds and patients to train medical students.
Right. Right. Okay. Well, Tana has the GoFundMe link on the screen, so people can go there. So it's a great cause, and we're going to certainly support it as well as a family. And what is it about the Lebanese doctors? We have so many friends from Lebanon who are physicians. So I imagine because of the civil war and other political unrest, people train and then sometimes leave. Huh?
Well, I mean, a lot of Lebanese, they we have a good education system, and a lot of people get educated, and you get to a point where you have to specialize. And back in the days, everybody wants to be a doctor or lawyer or engineer, right? And so there is a huge, cultural. And I can tell you, right now, from 3 medical school, now there is 6 or 7 in a small country because there's a huge demand. Everybody wants to be a doctor. And and once you get to, finish medical school and you train and you want to practice, the opportunities in Lebanon is not the greatest. The healthcare system is different than here. And insurance and government insurance is maybe covers only 40% of patients or maybe less. There's a lot of uninsured. So a lot of Lebanese doctors, when they finish training, and also training in the U.S. or in European country is really, really good. So a lot of Lebanese medical students, they immigrate, or maybe they go to different countries to get trained. Some of them hope to go back to Lebanon, and and others they stay, like myself.
Right.
And so, and the training over there, it's good because it's hand-on from day one. I remember as an extern, I was maybe like just started my clinical in 1995. I was reading different books in the ER to figure out how I'm going to suture and how I'm going to take care of different things. So you learn from experience, and you do a lot.
Right.
And so but once we travel and we go and visit the work, like I said, some of us will go back and others will stay.
Yeah. So let's move on. Great. Lebanon is now in big need of help in many ways, and what little we can do hopefully will alleviate some of the tragedy there and get the hospital back up and running. So you're a cardiologist. Let's talk a little about cardiology and COVID. There's a lot of interactions between what really is going on with COVID. So tell me, in your personal life and in your practice, what's going on, what impact has COVID had? And Nina, your wife's a doctor as well, so you guys are going through a lot, being in the front lines there. So I'm sure it's really disrupted your life, and also with 3 young children. So
yeah, it has been very tough. As you know, daycare is not an option. We're blessed that we have family here helping us raising 3 kids. 3 kids under 3 years old is not easy, but we're making it. Practice initially, got affected, significantly. My patient load or visit went down to around 30% initially, but it has been increasing since. And I think, July and August, we're having, kind of maybe close to normal month.
Okay.
I've seen. The hospital, of course, got affected because we had to cancel, postpone, or maybe delay some of the elective cases. Mm-hmm. So it has been tough, but it's, we stick together, we help each other, and things are turning around right now.
And you had initial shortage of PPE supplies, just from the get-go, right? You were using your N95 mask over and over and had to sterilize it and rotate it. Has that all been alleviated now? The supplies are good?
Yeah, so initially the hospital gave us 5, N95, and those 5.
5.
5. And they have to be used. They have to be used, every day you use one, and even if you use it several times, you have to kind of, you use one a day, and you have to put it in a Ziploc and put a date on it or a day on it. Like, this is a Monday mask, and you keep going Monday and Tuesday. You get to Friday, and then once you get to Friday, you can use the Monday because
you go Monday again. Monday. Yeah.
But right now, much better. I think, the Texas board have helped significantly take care of my wife. I mean, she's high risk. She was pregnant when COVID was hitting hard, and it's still hitting hard right now. But back in the days, I think in April they gave her quite a bit of N95, and she has been using N95 given to her by the board.
Right. Yeah, so N95 stands for that it stops particles of 300 nanometers 95% of the time. That's why you get N95. Sure. Whereas the other surgical masks are less. What has been the morale of the staff around you, the nurses and technicians, from, let's say, March to now? How is that going?
Well, I think the evolution is initially when you don't understand the disease, and there was a lot of panic, and definitely there's we're learning. It's every day we learn something new. People around me got infected. People got sick. And people that I know end up in the hospital for a few days, and very close to get intubated, and they were young people. But fast forward, we learn a lot, and I think you can see that initially we had a COVID patient, or some of them is person under investigation, PUI, which we don't know if they have infection or not. We used to be very careful, a lot of time hesitant to bring the patient to the cath lab. And in fact, initially we had a certain, protocol that the threshold of giving thrombolytics to patient with a heart attack was much lower than what it is right now. So that means, if somebody's having a heart attack, we used to use thrombolytics unless there is contraindication. And right now, more and more, we are using what we use all the time is emergency PCI, which activation of the cath lab and bringing the patient to the cath lab for a procedure.
Yeah, so just for the audience, cardiac catheterization is just the area where we take patients to take pictures of their heart arteries, put a tube in their wrist or groin, and a heart attack is caused by an artery in the heart stopping completely with clot, and you can open that up with a balloon. That's what is done normally in a stent. But since you wouldn't want to take that patient to the lab, you give them a medicine that we would use 10 or 20 years ago that would reopen the artery medically, versus taking them into another part of the hospital that could infect a lot of other people. So it had a major impact on how you practiced, and being fearful of patients. We're really never fearful of patients, and it's an unusual circumstance. When I talked to you recently, you had a rash of patients that came in with heart attacks at a very young age. We don't know whether that's related to COVID or not, but I found you had a 25 and a 29-year-old that you took to the lab, which is very unusual. Although Americans are getting heart disease at an earlier age, as we know.
Well, true. I mean, what I noticed is, the activation or cath lab activation, bringing the patient to the cath lab to take care of their heart because of heart attack, or even for what we call non-STEMI, which is small heart attacks. And for the audience, we have two kind of heart attacks. One is we call these heart attacks STEMIs, which on the EKG showing certain markers that there's ST elevation. And usually when you have ST elevation, the artery is completely blocked, 100% blocked. And non-STEMIs, that means there's no ST elevation on an EKG. And usually we diagnose those heart attacks with markers, cardiac markers.
Which is a blood test.
Blood test, yes.
Yeah.
And so the incidence of those two kind of heart attacks have went down significantly. In fact, describe in Europe and in US and in Italy and other part of the world that is about 50% reduction of admissions. Now, there's a lot of speculation, a lot of explanation, but I don't think there's any, one explanation why this reduction in heart attacks have happened during the pandemic. Is it because we are moving less? Is it because, some of those patients that they're, supposed to end up in the hospital with a heart attack, end up in the hospital with COVID infection? There's a lot of explanation. But one thing that I was described throughout the world, there is increased risk of cardiac arrest. So there's a lot of patients that died before arriving to the hospital, which sometimes you can think, and is it possible that some of those patients who are supposed to be in the hospital because they're having chest pain and they end up not coming to the hospital because they're scared of COVID and end up, unfortunately dying at home. So there's a lot of explanation, but yes, I have been noticing, and again, that this is anecdotal. I don't think it's that I'm seeing more, younger patients coming to the hospital with the kind of heart attack that we see a little bit in a little bit older patients in STEMIs, ST elevation, myocardial infarction. In fact, that day, I was surprised, and I have 25 years old who actually had a cardiac arrest while on the highway. 25.
25, yeah.
25, yeah. Had a cardiac arrest while driving in the highway. Bystander CPR performed. Patient brought to the hospital and took care of him, and he left home 2 days later. I had 38-year-old, lady who got admitted with heart attack. And in fact, this patient did not believe it. Said, "Doc, I can't believe I'm having a heart attack. No way. I'm young. I'm a female. No, I'm not having a heart attack. I can't believe it." And I said, "Yes, you did. And I took care of you, and you're doing okay." There's another one who was 41 that I took care of, and 45. And that was one day of bringing a patient to the cath lab with STEMIs, ST elevation myocardial infarctions. So
unusual to have 4 that young in one day.
It is unusual. It's not a trend because it's one day. So I'm not sure whether it's my colleagues nationwide or over the globe are experiencing same issues right now.
Yeah,
I'm not sure.
So is it totally safe for patients to come to the hospital now? You guys are completely ready and bent?
Well, the way I put it, it's maybe safer to be in a hospital than going to a grocery store. And the reason why I'm saying that, because one is this is a cardiac hospital, so we don't particularly take care of patients with COVID. We don't admit patients that they have a diagnosis with COVID. Then 2, we're screening everybody in the door. Everybody will get temperature check and then questionnaire whether they have a problem or not. And 3, everybody will have a face mask. I mean, those 3 things, face mask, maybe everybody goes to the grocery store in Texas will wear a face mask, but not everybody's getting their temperature check or questionnaire whether they have exposure to somebody with COVID. So I think it's safer to be in a hospital than go into a grocery store.
So on your elective cases, do you do a PCR? Do you do a nasal swab? Do they do that?
Every single patient that comes to the hospital, and I'm glad you brought it up, every single patient that comes to the hospital will have a nasal swab and has to be negative. On top of that, they're not allowed to bring their family. Only one person will be with the patient.
Okay.
So
every procedure that is done, that patient has to have a nasal swab, a test.
Yes.
The day of or the day before?
Day of, in the morning.
The day of, okay. And you get the results back how soon?
A few minutes.
A few minutes, okay. All right. And then if they have an emergency, obviously you've got to take care of them. If not, then you send them home? If if they're positive but asymptomatic, what do you do?
Well, I'm not sure if we had a lot of those cases, and I don't remember that I had to deal with one of those cases. And,
you've not had to cancel anybody?
I didn't have to cancel. I remember one time this patient had a COVID test that was positive in the ER and was having a heart attack. So I had to bring this patient to the hospital, but at the same time, we did another test in the hospital. The second one was negative.
Oh, lovely.
So, yeah. So, I mean, like I said, some of those tests are not pretty accurate. You know, you can get negative, you can get positive.
Yeah.
So,
So a topic near and dear to my heart is, prevention and diet and exercise. And right now we're seeing that people with obesity and metabolic syndrome have a much higher risk of problems and even death with COVID. So what are the things that you would tell people that are outside and want to reduce their risks for either COVID or other illnesses? What are you telling them now?
Obviously everybody needs to wear masks. I mean, wearing a mask is at this point of time is, I don't think it shouldn't be a political statement. Should be wear a mask to protect yourself and others. Because potentially you can bring this disease to your family member, to your mom, to your dad, your grandfather. You may not have risk factors. You may not be obese, or you may be, pretty healthy guy, or but your family members, some of them will get affected. So yeah, obesity is a major risk factor, and is a marker for developing severe COVID-19 infection, potentially ending up in ICU with a ventilator. So it is a big marker. And yeah, you're right. Metabolic syndrome is on the rise. And of course
explain metabolic syndrome to the audience. They may not know that.
Yeah, so the definition of metabolic syndrome, according to the NCEP, which is the National Cholesterol Education Program, they classify, they defined metabolic syndrome as having 3 out of 5 criterias. So, for first criteria is obesity, 40-inch waist, more than 40-inch waist in a man, and more than 35 in women. Triglyceride more than 150 or being treated for hypertriglyceridemia. Blood pressure more than 130/85 or being treated for, hypertension. HDL less than 40 for a man and less than 50 for women, and fasting blood sugar more than 100 or being treated for diabetes. So having 3 out of those 5, that will give you the diagnosis of metabolic syndrome. So, metabolic syndrome is a marker or predictor of, complication, predictor for cardiovascular events, stroke, and also a marker to develop diabetes. So some of those patients are pre-diabetic and they become diabetic. And obesity is the big risk factor for metabolic syndrome. In fact, if you take like normal weight person, his risk or her risk to develop metabolic syndrome is about 5%. When you become overweight, the risk will go up to 22%. And if you're obese, your risk will go to 60%. So it's exponentially go up with your weight. And unfortunately, I mean, the projection, right now the projection is in 2030, your obesity rate in the US will be 50%. Worldwide, right now, we have 645 million obese person worldwide. And it's projected in 2030 to be about 1.1 billion obese patient or obese person. So that put it in perspective, what the metabolic syndrome is going to be, the rate of metabolic syndrome in 2030 is going to be huge. It's going to be big. Mm-hmm. And it's going to bring with the diagnosis a lot of other problems, whether heart attacks, strokes, diabetes and its complication, hypertension and the complication of hypertension. So it's a big problem. And it's a problem that it is you can tackle this problem by changing your lifestyle,
Yeah.
by, you know.
Yeah. The other thing with metabolic syndrome, but specifically with the big waist, over 40 in men, over 37 in women, that's been associated with increased risk of cancer, including breast cancer. So there are several cancers, including kidney, breast, etc. The incidence of cancer goes up, death rates are higher, stroke. So the waist measurement is probably the single best, simplest measurement in medicine, to shrink that without using, cigarettes or cocaine, to do that. And what happens when the waist is really big, there's a lot of fat that infiltrates the liver. You get fatty liver, and fatty liver now is the second leading cause of liver failure, because hepatitis C has been cured. So, I think we are now able to perhaps more freely talk about obesity, which is very difficult to talk to people about obesity. Of the couple times that I've gotten in trouble in medicine in 30 years, is talking about obesity to patients. It's a very taboo subject, and it's not easy to talk about. And I think we should really take this opportunity with COVID to talk about risk factors, and especially in the low socioeconomic class. They have a lot of metabolic syndrome. Hispanic women perhaps have the highest, fatty liver incidence of anyone, and in Mexico actually just surpassed the U.S. as far as obesity rates, which is really kind of anything, including obesity. So what would be some simple lifestyle things that people can do to improve their cardiovascular risk and reduce their weight?
Well, I mean, yeah, you said it right. The Hispanic Mexican American, actually, the rate of having metabolic syndrome is about 45%. White is about 33%, and I'm talking about NASH here, because you were talking a little bit about non-alcoholic steatohepatitis. In a non-alcoholic fatty liver disease, there's two entities. There's non-alcoholic fatty liver, which not associated with inflammation and hepatitis, and the NASH is actually associated with inflammation of the hepatocyte and replacement of those cells inside the liver with fibrous tissue, and will lead to cirrhosis and liver failure. And of course, you mentioned about the obesity risk factor of hepatocellular carcinoma as well. Yeah, I mean, obesity is a big problem, and unfortunately, the way we are dealing with obesity is maybe lacking some of the important steps or education. We need to educate our kids, and when they're 2 years old and 3 years old and 4 years old, how to eat or what to eat, and how to move and how to exercise. When you start dealing with those obesity, with obesity at the age of 50 or 60 or 70, sometimes it's too late, because people develop fatty streak and atheromas. That means build up cholesterol in your arteries at a very young age.
At age 8 to 10 years old, the Bogalusa Heart Study showed that children as young as 8, 10, 12 develop streaks in their heart arteries, and plaque buildup starts then.
Yeah. So the education should start, parent to kids at age of, 2 or 3, and, they have to move, they have to exercise, they have to eat healthy. Diet is important. I mean, we have very carbohydrate-rich diet, which leads to metabolic syndrome and NASH. So we should be maybe following more of fruit, vegetables, nuts, olive oil, maybe less red meat. I mean, my formula, because sometimes you have to consult those patients when they come to our office, and I tell them it's very easy. It's very easy to remember. The diet is to.
Somebody asked about vegan diets and pescatarian diets.
I think it's a great diet. Any diet that you can follow is a good diet. And I would say a vegetarian diet is a great diet. But you have to be reasonable. Can you follow it? If you can't follow it, you just go for it. And my experience, a lot of my patients follow certain diet for a few weeks, few months, and then they stop. They get discouraged. They don't see results straight away, and they want to be losing a lot of weight. But it takes a lot of time, and diet alone is not enough. You have to exercise. You have to move.
Yeah. I think everything starts with a diet. You know, my experience with this is that you've got to find something that really works. There are a lot of fads out there. You know, for me, I see people doing this very high protein, high fat diet, the keto diet. What are your thoughts on that?
Well, again, I mean, if somebody has established coronary artery disease, I wouldn't recommend keto diet with high protein diet, you know. But again, it's a good diet to lose weight. I've seen a lot of patients losing a lot of weight with a keto diet. So yes, it is a good diet if you want to use it for a short period of time. If you don't have established coronary artery disease, and you're going to maintain your weight after, for instance, a few months of keto diet, to change it to a different diet that is more sustainable and healthier, like Mediterranean diet, and exercise, and that will be probably a better approach than using keto diet for lifestyle changes all along.
Yeah, so short term with people who don't have cardiovascular disease, because there's a big protein load, a lot of fat, and if you cheat on the keto diet, people will just blow up. I mean, that carbohydrate is going to just retain a lot of fluid, and to me, it really doesn't make sense long term. It seems quite unhealthy, and triglyceride levels will probably go up dramatically. Mm-hmm. Also puts a lot of stress on the kidney to clear all that. So I'm not opposed to it short term. One of the other things is that people need to learn about taking in low glycemic food. Can you explain that a little bit?
Well, I mean, this is what I talked about when I talked about nuts, fruit, and vegetables. They have low glycemic index, compared to sugar drink and juices, and that has a very high glycemic index. And that will increase your blood sugar significantly after you eat them, after you ingest those nutrients. And those spikes in blood sugar are, they're bad, which leads to a lot of problems, So that's the good thing about following the Mediterranean diet to me, which is very rich in the nuts, the fruit, the vegetables.
Right. What do you think of the intermittent fasting?
Again, we go back to, I don't think there's any trials or any studies that shows that intermittent fasting is the way to go. And I'm not sure if starvation is a good thing for your body, because this is when you start retaining, fat. So you use it if it works for you, but I think, like I said, the best diet that I would recommend is what you can, the diet that you can follow. And you don't do it for a short period of time. You do it lifelong. You do it lifestyle. Lifestyle. Nobody can do an intermittent, fasting as a lifestyle. You can do it for a short period of time, but you're going to have to transition to something that is more sustainable.
Yeah. Well, by intermittent fasting, I mean, there are a lot of definitions for that. There's some people that don't eat for several days and just have fluids. That I don't advocate. I do a 15-hour fast, so last caloric intake at night. So that forces you to eat early, and then don't eat for 15 hours. Don't have any caloric intake for 15 hours after that. That allows you to recalibrate everything, and then have 2 meals, 4.5 hours apart. So that's my idea of intermittent fasting. Because
Yeah.
I mean, in this society, people dine and they'll have a drink and food and have dessert, and that makes you feel guilty. But one way to get rid of that is just to go a longer period without eating, till the next day.
Yeah, I think it may work. I mean, if, like I said, I mean, it may work for you, but I'm not sure if it's going to work with a lot of people. I mean, if you're starving yourself overnight, this is when you start breaking your own muscles, because your blood sugar go down and your brain needs some sugar, and you start breaking your muscles, and you're not going to build muscles. Muscle recovery happens during sleep, and but it works, for other people, but. I think, you have to, some people can follow frequent, meals. When you eat small and you eat frequently, and they can lose the weight that way.
Yeah.
4 or 5 times a day, but you eat very small.
Yeah.
You kind of prevent those fluctuation in blood sugar from going too low and too high.
Yeah.
It may work.
What about sleep, George? That seems to have a big impact on satiety and food intake.
What is it? Sleep?
Sleep.
Well, I don't know what sleep is, but definitely sleep is important. For instance, patient with a sleep apnea, and that's not a quantity of sleep it's not a quantity of sleep, it's a quality of sleep. Some people with sleep apnea where they stop breathing during sleep, and they have a lot of apnea or hypopnea, or they snore heavily at night. They are patients with plenty of other problems, such as hypertension. So many times patients come to my office, try different kind of medications, not working. My blood pressure doc is 180 over 90, or pretty high, but you end up getting sleep study, you get them on a CPAP, and their blood pressure go down. Quality of sleep is important, and the quantity is important as well.
Right. So that's something that a lot of people really forget to look at if they're not feeling well, is to really evaluate, sleep and do apnea studies and sleep studies. Very good. Well, listen, we've talked for a long time. It's already been 1 hour. So, what was the name of the? Hey, Tana, can you put the GoFundMe site in for the Lebanese hospital that we want our audience to know? And George, do you want to say anything else about that before we end?
Yeah, I'm going to thank everybody who is, praying for Lebanon, and who is helping with any kind of any fashion, helping Lebanese people. That they're good people. They're helping the hospital, and I'm thanking everybody on my behalf and my family, and also if I can speak on behalf of Lebanese people, I'm thanking you guys for contributing and helping.
Okay. Hey, it was great to have you on, my friend, and good luck with the fundraise and the 3 new kiddos. Say hi to Dr. Nina, and we'll talk to you soon. Thank you.
Thank you for having me. Thank you.
All right, bye-bye.
Bye.